So anyway, so look at the light in the first eye, or you shine the light in the first eye, look at that pupil. Shine it again in the same eye, but you've shifted your gaze to the other eye, and you want to see that pupil constrict as well. Because remember, what one eye does, the other one does as well. So we're checking that equality. Now, we're going to shine now we switch the light over to the other eye. And again, just like we did with my right eye before, now it's shine it here, looking at this pupil, let it go. And then switch your gaze over to the right eye, shine the light again in the left eye. And it doesn't matter which eye you start with, you just do it. And then you look at the pupil react, the right pupil react as you shine the light into the left eye. Okay. So that's the proper way to check pupils, not what you see on TV where they're just, it's like, what the fuck are you doing? You practicing your hand wrist to be ready for tonight or something?
Oh my God.
Hey, I didn't say for what. You guys have dirty minds. You know, it could be they're getting ready for an Xbox tournament or something.
Yeah.
All right. When they're doing eye movement, they're doing a neurological check. They're checking cranial nerves. So you don't have to look at the conjunctiva. Looking at the snot up the nose. Inside the mouth, you're looking for any debris, broken teeth, loose dentures, cuts to the tongue, or cuts inside the mouth. Neck, you're looking for JVD. I talked about that. I don't know why they keep making it like they're freaking.
Because they're feeling rising you up.
No, what they're doing is, and to me, the hands are kind of high. Although I think she kind of likes them or something. But you want to squeeze in from the side. So you kind of want to wrap your hands around the chest and press in. And then in the center of the sternum, I didn't show it. You also want to press down on the sternum to make sure that the rib cage is intact up there. Okay.
Do you use your whole hand, or do you
Yes.
just use like? Okay.
No, to palpate, you use your whole hand. Yeah, you don't get a lot of information. Just you need to press. You need to feel, and that's why I tell you guys you can't be shy. And once I get you in that classroom, I want to see. Forgive me for saying this so crudely, but I want to see you guys touching each other. So, because that's the only way to learn. Number one, and that's the only way to gather information. If you don't touch, you don't find out. You remember how I said roll your hand over the abdomen?
Yeah.
She's doing a good job of that part. You don't want to just, okay, does that hurt? No, you're not getting any information. This is more for appendicitis where the heel drop test. If they're unresponsive, you could just jam the bottom. And there's checking the pelvis. Remember I told you about pressing down on the wings of the pelvis? So the heel of the hand, just press down. And then you could squeeze in to continue checking for the stability. Now, this is a guy.
I have small hands.
That's okay. The other thing, and it sounds kind of raunchy, but you got to look at his package. You have to see if you notice a bulge. And the way to do it, actually, let me rephrase that. The way not to do it, let's say this is the package, right? You guys see my mouse?
Yeah.
Okay, you don't go like that. You don't grab it and squeeze. Okay, no, ow. Okay, use the back of your hand and brush and feel if it's erect. Okay. And what you might see, especially with shorts, but what you might see, and again, it's hard for me. I mean, I'm saying erection, but just to give you maybe a better pictorial, and I apologize for this, I really do, because especially because we're recording. The better pictorial I could give you is tenting. You see the shorts lifted up, or maybe the pants are lifted up a little bit, and that's indicating that there's an erection underneath. Counter pressure, might feel. This is a little bit more, again, checking the nerves, the dorsiflexion, the plantar flexion. And I think it was you, Rosie, that asked about the Babinski. With a head injury also, the other thing that we want to do is we can I don't do toe jump very well. Is with the foot flat out, you can get your pen or something, or even your finger is fine. Don't get something sharp. Just get something. Again, pens work pretty good. And you just go up the foot. Can you imagine the tickle?
Yeah, the reflex.
Yeah, normally we curl the toes down. Well, the Babinski reflex, which indicates a severe severe brain injury, is when you brush it up, instead of going down, they curl back like that, but they also fan out. Your toes fan out, and they're curl. Obviously, I can't do it with my hand, but they curl back like that foot is doing. And so if you have that, it's a positive Babinski's reflex, again, indicating a severe brain injury. We don't want to see a positive Babinski.
Right? With
What was that?
They do that to babies too for their response, right?
Well, they do it on anybody, but if they're checking for Babinski, it's to gauge whether they have a significant head injury. Or brain injury. So, all right, here they're checking for a pulse. If it's something you're going to keep rechecking, then what I would do is get a Sharpie. You should carry a Sharpie on you. You never know. And put an X over the spot where you found the pulse. So that way, when you reassess, it's real quick. You already know where to check. Okay. This part of the assessment, I don't like, because you're having the patient press down on your hands like they would a gas pedal. However, when they're pressing down, you're pushing up, and you can move them. And I'll show you guys whenever we go back to class, I'll show you guys what happens, but you could jeopardize the spine in that. The only time you should be checking pushes and pulls is if you suspect a stroke. Other than that, I don't recommend doing this. I totally disagree with that. I hate this part of can you feel me touching? He has weird toenails. Yeah, I don't do feet. Sorry. The best thing to do with the upper extremities, I'm checking two different nerve groups in the spine. And so for the upper extremities, I do medial and lateral. So I just brush with my finger. Can you feel this? Can you feel this? Can you feel this? Can you feel that? Now, this is my lower extremity. Instead of medial and lateral, I do anterior posterior. So here's the ankle. So can you, medial or anterior posterior. So can you feel this? Can you feel that? Can you feel that? Can you feel that? Okay. Because what people tend to do when you say, which toe am I touching? They'll look down and they'll tell you, oh, my big toe. Well, that kind of defeats the purpose of can you feel it? Now, I'm glad that the optic nerve works pretty good, but I really don't give a shit about the optic nerve. I care about L5, S1. I care about L4, L3. Way further down. So, and I tell people, check the different nerve groups, and what they do, they check, like they'll touch the big toe and then the little toe. It's like, what the fuck? Okay, you are checking two nerve groups. But again, they're seeing which toe you're touching. I don't care if they can see. Okay. I'm very opinionated, have you noticed? Just gonna ring them. This is done during a stroke. Arms out, palms up. If you have any drift or pronation, then it's a positive test.
What was it again?
What?
What is it? What? Can you just repeat what you said?
Oh, I said that arm drift test
Mm-hmm.
is done for strokes. So you have them put their arms out, palms up. Any drift down or pronation, meaning turning it in, is a positive test. Positive stroke test. So is the smile. That's done for a stroke. Although it looks like he has a hematoma or a cyst or something. More about
A smile is a positive?
Yeah.
No.
The
Right? The facial droop, right?
Yeah, facial droop is. That's why you have them smile.
Oh, to see if one side doesn't lift.
Exactly. You want both sides to be up and tight. If you have one side smiling and the other one isn't, or even droopy, then positive facial droop. If it's all equal, then that's negative. So I mentioned.
Scale, right?
What was that?
No, nothing.
Why is it that after a stroke that your face stays like droopy?
Because there was damage to that part of the brain. And so those nerves are now, or that part of the brain now is inactive. And so there's no muscle control because of the lack of nerve impulses from that part of the brain. Good quick answer?
Yeah.
Yeah, the brain is a very important organ. It does a lot. Then you throw in the heart, and then you got both of them battling, and then you're like, oh, fuck, what am I going to do? My brain is telling me this is it, but my heart's telling me this is it. Right?
Yeah.
That dilemma.
Yeah.
I think that's a normal part of life, having those kinds of dilemmas. It's like your heart is really set on that cig, but your brain is telling you you don't have the money. But I really, really want it. Well, you can't have it. Let me answer an email real quick. Sorry, guys. But I'll keep talking. So what were you saying? So yeah, the nerves are really dictated by the brain. That's why when somebody's brain dead, there's no bringing him back. The brain is dead. You don't have any respiratory control. You don't have what are you doing? You don't have anything. I mean, the heart's still beating because it doesn't require the brain, but other than that, it's pretty difficult.
Well, it's like some of those cases where, what do you call it, like when they're in vegetable state and then they come out of it.
A miracle?
Yeah.
No. In that case, their brain is still working. Once the brain dies, that's it. There's no bringing it back. There's no bringing it back. So there's not much else to do. That's where they might put them on a respirator to keep the oxygen flowing, because the heart's still working. So they're pushing blood, or they're oxygenating the body, and the heart's still pushing the blood throughout to preserve the organs. And they're probably going to be organ donors. All right. As far as sample history, I didn't expand on it too much. The signs and symptoms, and I got to put this. The questions. I didn't put the questions on for you guys. I have sample questions. Now, when it comes to the signs and symptoms, we're talking about what is the patient experiencing. Now, a sign is something that you can see, something that you can measure. So the patient's vomiting. Can you see the vomiting?
Yeah.
Yeah. The patient complains of chest pain. Or no, let me change that. The patient complains of a headache. Can you see a headache?
No.
Can you
No.
prove it?
By signs and symptoms. Asking them what they feel.
Yeah, but can you prove a headache?
No.
No. No.
So that's a sign, something that you could see or prove. A symptom is what you can't see or prove. So that headache is a symptom. Nausea, again, you can't prove it, is a symptom. So that's a difference between a sign and a signs and symptoms. Sign is what you could see or prove. Feel my heart racing. Well, you could prove a racing heart by taking a pulse. Like I said, vomiting, shortness of breath. Well, that of itself might be a symptom, but the sign is the patient's tripoding, the patient has nasal flaring. Okay. And coming back. All right. So allergies. We don't really need to know if they're allergic to grass. We don't need to know if they're allergic to pets. We don't need to know that if they're allergic to work. Oh shit.
Is it more like they're allergic to some certain type of medications? Like,
Exactly. That's what we want to know. Are they allergic to medications? That's what we really care about. Are they allergic to medications?
can
I
we
just
ask them
spilled
if
like
they
half
carry
a
an
monster.
EpiPen?
Only if they're having an allergic reaction. Now they say I'm allergic to bee stings. Okay, well, but you twisted your ankle, so what does that have to do with anything? You see what I mean?
Like, I'm allergic to iodine, and I didn't know until I coded when I was getting a test done.
You coded?
Yeah.
What the hell?
They tried to blame the morphine, but
They coded you with iodine. So now you know what kind of stuff to avoid when you're allergic to iodine?
Oh man, yeah, that was a scary experience.
It's like you can't have shellfish, like shrimp. This close. All right, where? Sorry, I just spilled my Monster on my little desk. So let's try to clean that up.
You sure you're not looking at it from the table?
I'm sure because most of it went to the carpet and it's soaking up my carpet.
Nice. Good job.
Thanks, I try.
I'll be mad.
It's like I usually don't put my drink on this little table because it's all fucked up. One of the wheels is coming off, so it doesn't roll very well. And so it kind of fucked things up. All right, anyway. I'm glad it's sugar-free, so it's not really sticky. So allergies, yeah, we want to make sure it's medications that they're allergic to. Shellfish, though, is important, or iodine. What else?
Pain meds.
Yeah, any type of
Codeine.
pain meds. So any medication, any medications that they're allergic to.
You know, a lot of people are allergic to penicillin.
I'm not. But yeah, my mom is.
Yeah, my mom is too.
So that's important, especially when you can do treatment like wound care. Find out if they're allergic to anything. If they're allergic to penicillin, bacitracin is okay to give. Although I was reluctant at first, but
I
no,
mean, they usually tell you if they have a major reaction to any medication, right?
Not all the time.
But what if they're unresponsive and they're allergic to pain medication or something you're going to give them?
Yeah. If we don't know, we don't know. But like with pain meds, they're unresponsive, so it really doesn't matter whether we give them pain meds or not because they're not in pain. They're unresponsive. But other medications like lidocaine, if we give that for cardiac arrest and they're allergic to Novocaine or the canes, then whoops. But you got to do the best that you can. As far as medications, I think I told you guys, we want to know medications prescribed by a doctor. So you could say that. You could ask them, are you allergic to any medications? I'm sorry, do you take any medicines? Or do you take any medications? And they might give you a list of all this other stuff. And they take vitamin D, they take folic acid, they take prenatal vitamins. Well, prenatal vitamins are important. They give you all this stuff. It's like, I really don't care what supplements you take. I just care about any medications that are prescribed to you by a doctor. And so you could expand on that. Because there's a race, at least one race that I know of, Mexicans, that you ask them a question and you get like a 30-minute dissertation on what happened on Mother's Day last year. So
Yeah, pretty much.
yeah, exactly. And you're like, yeah, I don't care about your compadre Tomas that, you know, the comadres were doing this and this and this. So it's pretty interesting. Past medical history. The only thing on that is, do you have any medical problems? I had a question. What do we do if the patient is deaf? Most people don't know sign language, so it's okay. Some of them, or a lot of them, I think, can read lips.
Can you just like write it down and show it to them?
Yeah, that's the other thing. That's why you should always carry a notepad. Well, that's one of the reasons why. The other reason is to write down vitals and things like that, so you can transpose it over to your documentation. But you want to have that notepad there to write that stuff down. Like I said, a lot of them can read lips, so just speak slowly, clearly, so they can read your lips. And then they can nod or shake their head. Past medical history, usually it used to be past pertinent medical history, but find out what their medical history is so that way you kind of know maybe what's going on with them. For example, and they might not think about a couple things, but for example, if they're having abdominal pain or flank pain and it's radiating to their groin, that's indicative of a kidney stone. So you want to ask them, have you ever had a kidney stone? Yeah or no. If they say yeah, all right, did the pain feel like this? Yeah. It's safe to assume, although I'm using that word very loosely, cautiously, that they're having another kidney stone. If they're having chest pain, have you had a chest pain before? Yeah. Did you see a doctor for it? Yes. And what did they diagnose you with it with? Angina. Okay. Does it feel the same? Yeah. Okay. Or maybe they had a heart attack and it still feels the same. So that's all part of history taking. That's all part of talking to your patients. Okay. All right. Last oral intake, like I said, that's really not so important. The only time it really is important is one, if they're going to have surgery. So it's good to know when the last date so they can relay information to the anesthesiologist. The other thing is it could be maybe they have some sort of abdominal problem and that gnarly Mexican food from last night is what's causing the problem. Or B, maybe they haven't been eating very much because of their condition, and so now they're feeling weak. So that would help in that case. But other than that, really, there's not a lot of reasons to ask that. The events prior to this event, it kind of, events prior to the event. I love that repetition. Let me rephrase that. Where this comes in handy is when you're doing the PQRST or OPQRST onset. What were you doing when this happened? So again, we have that redundancy of the O of, okay, what is it? It sticks its nose in a lot. Ding, fries are done. Remember that from a few years ago? All right, this is what I wanted to go over. Now, I know you guys read the book and it talks about the Glasgow Coma Scale or GCS. Did you guys want me to go over GCS also?
Sure.
Yes.
Okay. Because you guys didn't read it, so you just want me to do the work for you. I see how it is.
No, not at all.
No, okay. Glasgow Coma Scale. The Glasgow Coma Scale is a way to, there we go. It's a way to kind of see what the patient's mental status abilities are. And so we put a number to it. And we could see whether the patient is going to be okay or they need some interventions. Now, anything less than 15, actually, let me back up. The highest score a person can get is a 15. The lowest score is a 3. Now, the thing about this is that it really doesn't differentiate. So your beds that you guys are laying in right now, listen to me talk, that has a GCS score of 3. So everything has a score of at least 3. Anything less than 15, 14 or less is considered altered. And now you start going down, and 8 or less, they're getting it tubed down their throat. So depending on the reactions or on the responses, it's going to determine what score they get. So right now, everybody, your eyes are open. You didn't need any prodding, and the alarm doesn't work. You didn't need any prodding to open up your eyes this morning. Even if your alarm woke you, you still closed your eyes again, but you eventually said, I got to get up and listen to Lou again. Oh, I got to talk to you guys about that. And so you spontaneously opened your eyes. So that's a 4. That's the full score of spontaneously open your eyes. Remember I talked about tracking? If they're tracking, they're a 4. Now, if they're not open spontaneously, and you have to say, sir, open your eyes. Now you know why I say, sir, open your eyes, or ma'am, open your eyes. Because I'm giving them a verbal command. Wait, actually, let me rephrase that. I'm giving them a verbal command. If they open their eyes up with that verbal command, then it's a 3. If they didn't, now we use a painful stimulus. And if they open their eyes with their painful stimulus, then that's a 2. And if they didn't respond, then they were unresponsive. No response, because they're unresponsive, then it's a 1. That's the lowest score. Did you guys hear my accents on words? Hello?
What do you mean?
Of how
Verbal
you
command.
emphasized. So.
Painful stimulus.
Yeah.
Unresponsive patient. Why did I do that?
To make it clear.
Key words on how to grade them.
Uh-huh.
Half poop.
There you go. That was Paul, wasn't it?
George.
Oh, George. Sorry. Way to go, George. George, why did you say that? You're right. Why did you say it?
Because you're checking for alertness, verbal stimuli, painful and unresponsive.
There you go. I was hoping you guys would get the verbal, pain, no response, alert, that you would see that relationship. So based on the AFPU scale is going to determine what their eye-opening scale is. So yay. Oh, you just made my day. All right, next up is verbal response. So it's a little bit different now. With verbal response, we are going to look at what they're saying. Now, in legal, remember we talked about the questions we asked them? Rosie, can you hear me? Okay, everybody's too quiet. Can you guys hear me?
Yes.
Yes.
Okay.
Yeah.
How come everybody's quiet? Speak up.
What was the question?
My question was, do you remember back in legal, medical, ethical issues when we talked about consent and asking them the 4 questions?
Yeah.
Vaguely, right?
Yes, vaguely.
What were those 4 questions?
Wasn't it like what is this date? What year is it? Where do you live? And
Or who was the president?
oh yeah, there you go. That one.
That
Kind of,
already
sort of, but there was 4 categories.
Person, time, place, and event.
Yep. Person, place, time, and event.
Yeah.
Okay. So we ask them that. And they're talking regular to us or answering our questions appropriately. They get a 5. They're oriented and they're talking just normal. Now, if they answered the 4 questions correctly, we say they're A&O times 4, alert and oriented to the 4 questions. Times 4 is the 4 questions. But if they're not A&O times 4, let's say they're A&O times 3, then they're disoriented or confused. They're still talking, but they're confused. They didn't give you all the right answers. So in that case, then they would be a 4. Now, if you ask them, because I'm seeing screen, and I asked George, can you tell me what day it is today? And he says, Mary Poppins. What? What does Mary Poppins have to do with the day of the week?
Would that be a 3?
Mm-hmm. What was that?
Will that be a 3 then?
Yeah. But again,
Is
what
there
does,
not a correct answer for this?
what do you mean?
How do I put it in words?
Well, like, what if he's just being like sarcastic? What if like the person's being sarcastic?
You can tell.
Yeah, I was about to say, you could probably
Yeah.
tell.
Mm-hmm.
Yeah.
If you think they're being sarcastic, then say, why did you call us? Why are we here?
Yeah.
You know, really, why are we going to waste our time on somebody?
But
It
you
sounds
always get
cliche,
those
but
calls, though.
what?
You always get those calls, those old ladies that just want someone to talk to.
You say scheduled calls?
No, we always get those old ladies that just want someone to talk to and they just call.
Well, if you determine it's not a medical emergency, just cut it short. There's nothing wrong. Yeah, we're there to help people and to serve the public, but there has to be limits. You can't abuse the system. And I was going to say, without sounding cliche, but there are people that could be having a heart attack or some major event. What if, and I apologize for this, I don't know if it's still a tender topic with some people, but Rosie, you know what I'm talking about, where you can't get help right away, but there's a child that's choking or not breathing. And you're there with some sarcastic asshole. Excuse my rudeness and bluntness, but if they're going to be sarcastic, just tell them, you know what? If you're not going to answer me appropriately, then we're going to leave. So get firm with them. Don't put up with that stuff. And even with students in my advanced class, I have some sarcastic assholes.
Well,
And I don't put up with it, and I tell them that.
Damn.
You know who's perfect job for this? Mercer. Oh, what's his name?
Mm-hmm.
That's him. Refusal.
Sarcastic? Oh, yeah.
Yeah.
Yeah, he's very sarcastic. He has a very dry sense of humor. But yeah, he won't put up with bullshit either. He hates bullshit.
He'll tell you straight up. You're wasting my time. He'll tell you straight up, you're wasting my time.
Mm-hmm. Yeah, Mercer was also a student of mine. But not for EMT. I'm not that old. Well, I am, but. So anyway, inappropriate words is something like, wait, what does that have to do with anything? Because remember, you've been talking to them, so you should be able to get a feel for how with it they are. So anyway, if they said something inappropriate, like, again, what day is it? Mary Poppins, or what's your name? Purple People Eater. What? No, who? Although Elon Musk just named his kid, I don't know what the hell, but named him something. So that's a 3. If you're talking to them, you know, they have their eyes open, but they're could you understand any of that?
No.
No. So that's incomprehensible sounds. That's a 2. If they're not able to talk whatsoever, then that's the 1. Again, lowest. And then lastly, motor response. So right now you're there, you're clicking, you're doing whatever else, taking notes. That's a spontaneous response. You're obeying. The other thing is, although you can tell them to do this or to do that, and they do it. But as long as they're moving stuff without you telling them to do, that's fine. That's a 6 for verbal. I mean, for motor. If they don't have their eyes open and you do the painful stimulus, what localizes pain is let's say you're doing a sternal rub and they go and grab your hand or your wrist. They know where the painful stimulus is coming from and they're localizing it. They're grabbing your hand to have you stop that. So that's localizing. That's a 5. If they withdraw from the pain, instead of going to grab it, they kind of go away from it, then that's a 4. The next 2, the flexion, the decorticate, that's a 2. That's a 3. Remember I showed you that earlier? So you're doing that painful stimulus, and instead of localizing or withdrawing from it, they just start to what we call posturing. And the decorticate is bringing the arms up. So that's a 3. If they have the extension or the decerebrate posturing, then that's a 2. And if they don't respond whatsoever, then it's a 1. So again, the lowest score you can get with GCS is a 3. The highest you can get is a 15. All right. So 4.65, that's the way that I learned it, but now it's 4.56 is the highest score.
Can you go back real quick?
To what?
That one.
It's also in your book.
Oh.
372. Page 372.
Can I keep going?
A lot of
Yeah.
pace there.
What was
Yeah,
that?
go ahead.
So I wanted to expand on decapitalis a little bit more. Does that look normal?
No.
No.
Hell no.
Looks gnarly, doesn't it?
Yeah.
Yeah.
So that's a deformity, something that is deformed. Everybody recognized right away that that is not normal. This here, that's the tibia. And so you have the malleolus. Oh man, I love that. Contusions, fancy word for bruises. Although this here is a hematoma, the swelling, But you see the bruising? Those are contusions. And they don't have to be around the eyes. They could be anywhere. Abrasions or scrapes, probably road rash from a motorcycle accident. Torns, contusions, abrasions, punctures, and penetrations. Good little puncture right there. Tell me what structures could be involved.
The liver.
The liver's like right up in here. What was that?
Stomach.
Okay, the stomach goes through here, maybe a part of it.
Spine.
The what?
Your spine.
Okay, if it went all the way through, okay.
Would it affect some of your parts of your lung, the bottom part?
Nope.
Oh.
The lungs are go to about right there.
Is that like a gunshot wound or what is that?
I don't know. It's
I
too
mean, if
big
it's
to be
a
a gunshot.
gunshot wound, probably your lungs as well, your liver, all of that.
That's in the center, so it missed your lung.
Yeah,
And
but
then the
if it's
heart's
like
right over here, so it missed the heart.
a hollow point, you'll break through all that.
I know, but we can't assume that it's a gunshot wound. It doesn't look like one.
Stomach.
How about the small intestine? How about the large intestine?
More.
Yeah.
Close to the diaphragm?
Yeah.
How about the pancreas?
Oh yeah.
Burns, second degree burns right here. The reason I know is because of the
Blister.
blisters. Blistering causes second degree burns. I mean, secondary blisters are a sign of second degree burns. Tenderness, just basically you touch it and it hurts. The next one is swelling. So you notice how this is puffy as opposed to this? And
And
kind of
white.
seen some, huh?
And you can see the white spots.
Yeah. Now with the wounds here, and he doesn't have them here, I would say he has an infection going on under here that's spreading throughout his hand.
Looks like a
Could
staph.
there be an allergic reaction?
No. What were you saying, Sequoia?
It looks like a staph infection.
Very well could be, because remember, 33% of us have MRSA on us.
Yeah.
And Staph flora. So yeah, with those, especially this right here, that'd be my guess. He got something in there and it got into the tissue and it started causing the infection.
There's like a little cut on his little, or the finger, the smaller ring finger.
Yep. Lacerations, kind of a jagged cut. Later on, when we get to neck emergencies, we'll find out that this could be a bad thing. We need to use an occlusive dressing to cover this up, and then we might get.
JVD.
Well, he's laying down, but yeah, there's some JVD. Remember, I was telling you guys about looking for JVD, jugular vein distension.
Yeah.
This is what it looks like. That jugular vein is swollen. And as a paramedic, I could start an IV on that vein right there.
The neck.
Yep.
Ouch.
No, it's more like, oh yeah. EJ. I don't know why they're showing this for swelling, but
I think that one was supposed to be for tenderness.
Mm-hmm. Yeah, it could be. So, start.
That's a good one.
His ear looked all weird.
Yeah, that's pretty good jugular vein distension. But see something else gnarly. Look at his ear.
That's what I was just saying.
The
A
bruise
little
ear.
bit cyanosis, a little bit ashy. And you notice how he's sweaty?
Yeah.
So he's intubated right now. That's the tape we use to intubate or to secure the tube. So this guy's kind of foobarred. I gotta remember what movie that came from. Now check in the neck, put on the collar. And you don't have to do it now. You could wait till later. Again, they're filling him up. Listen to lung sounds. Palpating the abdomen, the pelvis. Oh, it looks like he has a small hernia.
In his belly button.
What was that?
In his belly button.
Mm-hmm. Roll the back, palpate the spine. Rosie, what did Wyatt teach you when you're palpating the spine?
You had to go all the way down to her coccyx.
Uh-huh. A colleague of mine teaches you got to go all the way down the coccyx. So you see the border right here between the back and the, oh, no, you don't go there without buying me dinner first. He goes past that. He says, screw dinner. I'm going straight for it. So he goes like down into here. It's like, whoa, type of thing. I don't teach that.
I remember Brian yelled at me
Why?
because I was being shy when we're palpating the growing area.
Hmm?
And he literally told me, no, you fucking grab. And I'm like, oh, shit.
You got to remember, I'm a lot more modest than some of my colleagues. So I'm not going to grab. I teach you guys ways to not get yourselves in trouble or not to be overly aggressive. Because people nowadays, I'm sorry for saying this, but people are really sensitive nowadays, very delicate.
Yeah.
So any questions?
No.
No.
Okay. So the next thing I want to do is there's a video I want to share with you guys. It's on patient assessment. It's a different way to look at it. What I showed you was literally, and I told you this, was teaching to the test. But I don't want to create robots. I want you guys to be free thinkers. I want you to kind of go with the flow. And that's really what I'm looking for now, and I'm judging, and I'm showing you how to interact with patients. So let me find that video. And I messed it up again. Because I always forget to share the audio. Damn it. I don't know why sometimes it does and sometimes it doesn't. Can you hear that?
No.
No.
Practical way to
Can you hear that?
Yes.
Yeah.
We created a flowchart showing you this 2-page flowchart on your screen. You'll be able to download this through a link at the end of the video. You'll see
Is it too low?
Yeah.
Yeah.
What we've done.
I'll be right back.
Sounds good.
All right, guys, can you see me?
Yeah.
Yes.
Hear
Yeah.
me?
Yes.
Yeah.
Yeah.
Can you hear me now?
Good.
Yes.
Guys, say something so I can know my speakers are working.
Yeah.
Yes. You're
Be good.
I can't hear anything. I
good.
see thumbs up, but I can't hear
Can you hear
anything.
me?
You can
I
hear.
can hear you. Can you hear us?
Can you hear
We
me?
can hear you.
Yo. Can you hear me?
How about now?
Does that work?
No.
Good
Oh.
with Sequoia though.
Mm. So you can't hear us?
Guess not.
Distress, abdominal pain. Maybe they fell and they hurt their hip. Whatever it happens to be, we assess
Can you hear that?
body systems
Yes.
based on that.
Yeah.
Altered
Yes.
mental states. We have to assess many body systems. There could be a lot of things doing this. Because here's the thing, as an EMT, you not only have things that you can do to treat conditions, sometimes you have multiple treatments that you can do with a patient complaining. If the patient has an altered mental status, we have naloxone for opiate overdose, we have glucose, and we can also identify stroke scales and cardiac, do cardiac patients. We have to transport more quickly.
Can you guys hear that?
Yeah.
No.
I can
Yeah.
hear you now. I switched to my headset now. I could hear you guys. All right. So I will play this out. Wait. Oh shit! I moved way over there. It's like 11 minutes. Like, no, that's not true.
This is Limmer education.
So, this is Dan Limmer. He actually writes one of the EMT textbooks. We don't use his, but he does write one of the EMT textbooks. He's actually a very well-known educator in the country, and he's part of the Texas Association of EMS Educators. Although he lives in Maine, and that's where he primarily teaches, but he speaks at different conferences. And so he does a lot of good things, and he's helping with a lot of what's going on in the country right now as far as helping EMS education. But this is something new that I saw, and it's pretty good, and it kind of does go against what I taught in some ways, where I tell you guys it's always the ABCs and it's in that order. And by the way, I forgot to give you guys 2 exceptions to the ABC rule. Okay. So always, always, always remember it's ABCs first in that order, and you can't go on to the next step until you clear the previous step. But there are 2 exceptions to the ABC rule. Okay, you know what they are?
No.
All right. The first
No.
exception is C-spine. Okay, the first exception is C-spine. So all you have to do is just grab the head, keep it in line, and you're good. The second exception is stop the burning process. Kind of makes sense, doesn't it? If they're on fire, I mean, you can kind of tell if they have an open airway and they're breathing, they have pulse because they're running around screaming, they're on fire. Stop the burning process. Those are the 2 exceptions to the ABC rule. Now, where Dan kind of changes it up is do what's going to kill the patient first. Doesn't matter if it's ABC or CAB. Take care of what's going to kill the patient first. Makes sense, doesn't it?
Yeah.
Yeah.
We're trying to not train you anymore, and actually, believe it or not, I've known the state EMS director, Joe Schmieder, for 5 years now. Really, really nice guy. And when I first met him, we actually had a very interesting conversation. And he says, should we be training our students or should we be educating our students? And what's going on in EMS is, and what's been going on for a long time is, we've trained our EMS students. Like you guys. We train you to do a certain skill. Well, guess what? I hate to break it to you, but we could train monkeys to do our job. What we want to do is we want to educate you. We want to make you guys free thinkers. This is why I'm not satisfied with you just knowing the answer. I want you to tell me why you chose that answer. That's why I do why. Because I'm trying to educate you to be a better provider. And as we do more and more educating, not just training, but educating, we can get rid of the stigma of, oh, they're just an ambulance driver, or oh, they're just a tech. No, we want it to be something that people could be proud of.
and show that we're worthy of more recognition. So, and higher pay. So anyway, breathe, Lou, breathe. I'm just excited thinking about the brunch, the Sunday brunch on a Thursday. Anyway, you guys there?
Yes.
Yeah.
Okay.
Yes.
I'm getting a
Yeah.
message. I was just trying to make sure that you guys can hear me and I wasn't just talking to myself this entire time.
Don't tease me with a good time. And I don't think the bars are even. I don't think they open.
They're not
I
open
think they
yet?
were. I don't think so. I think they were gonna hold off.
Hey, brunch at someone's house.
What, is Rosie volunteering it?
I'm down.
My
Did
fridge
you
is
hear that,
full.
Spoya?
Yes, I did.
Brunch at Rosie's house.
I'll get it me.
Wait, Rosie, are you in
All
District 2?
right, all right.
Am I what?
Are you in District 2?
No.
District 1?
Yarborough and Edgemere.
Oh, okay, so you don't live on the res.
Hell no.
Okay. Hey, I'm near Edgemere too.
Nice.
Alrighty. So we'll talk about it after. But brunch at Rosie's.
Yeah.
All right. So here's the video. Have fun.
Patient assessment. In this video, we're going to show you an intuitive, easy, and practical way to look at patient assessment. My name is Dan Limmer. We've created a flowchart. We're showing you this 2-page flowchart on your screen. You'll be able to download this through a link at the end of the video. You'll see we've taken patient assessment and broken it up into some of the traditional components. What we've done is we've gotten rid of some of the baggage that's come with patient assessment. I've watched Facebook study groups and talked to students who struggle with knowing the difference between terms that might not matter or terms that are outdated, the focused and the rapid exams. In fact, patient assessment should have a flow and be intuitive. And I wanted to show you the whole thing. There's 2 pages. Now I'm going to break it down into parts. I'm going to explain to you what I believe patient assessment should be for you so it's understandable and practical, whether you're talking about the classroom or your practical exam or the street. In this first section, we're going to talk about scene size up. Scene size up, if you put it into a sentence, is big decisions that affect the entire call. And you see 1, 2, and 3 across the top of the page. Is the scene safe? If not, call for police. Now, scene size up in the safety in a crazy world today. You know, you may come upon somebody who's in a car that's on fire. You may find yourself in a spot where there's violence and bleeding. And if you decide to take a risk, I would just say evaluate the scene carefully and do it wisely. Safety does remain the most important concern, because if you are a patient yourself, you can't help and you become an extra patient the system has to deal with. Now, 2 and 3 have to do with needing help. Number 2, do you need ALS? Do you need extrication? Is there a fire? Hazmat? And number 3, how many patients? If there are multiple patients, you're going to have to call for help and then switch to triage mode. You know, triage mode's a different animal than when you find just one patient at a scene. So those first 3 I call the operational component of the scene size up. Right? You may in class learn, there's so many different decisions. They are decisions, not steps. But there's really 2 different phases. The first is before you get to the patient, and the next part of the size up is as you approach the patient. Because from the second you get that patient in sight, you're picking up important information. So take a look at the patient as you approach. Before you get there and kneel down and say, "Hi, I'm an EMT. I'm here to help you. What's going on today?" You're going to look at him and you're going to see things. Is the patient lying on the ground in front of a car that just struck them? Right? Do they have they fallen from a tall building and they might need C-spine? Or is it a medical patient, and as you approach, they don't look very good. They've got poor color and in a tripod position trying to breathe. Now, what's interesting is is that when educators and you listen to videos like this, watch videos like this, we always tend to use the serious patients for examples. But there's going to be times when you get to a patient and they're sitting on a bench in a park and they say, I think I twisted my ankle, but my wife's going to bring me to urgent care. I'm all set. And that not every patient is serious. That's the nature of this. And quite frankly, as we bridge from the scene size up into the primary assessment, look at those green boxes. Your first look at the patient. Get a general sense of problems and priorities. Because every one of these phases of the patient assessment process prepares you for the next. That's the flow. We often teach these in separate chapters, or we break them up in our head into separate things. But the truth is, those things you observe in the scene size up set a foundation for a call, not only in those operational sections to make sure you've called for the help you need and that it's safe. And by the way, if you don't do those early, we tend to forget or get in the middle of a bad situation we have to deal with. That's really important. But remember, those first observation of the patients lead us to the primary assessment and the next visual on your screen. Primary assessment. Here's the sentence that describes it. What immediate actions are necessary to keep the patient alive? Right? I mean, that's a big thing. Now, again, let's go to the green boxes. Some patients need only minimal assessment and care in the primary assessment. You get a really alert patient and they're telling you what's going on. And while we're going to do some things like check their pulse quickly and their skin color, temperature, and condition, if they're alert, they're probably not in respiratory failure. The mental status is very, very important. So they're breathing, and yes, they have a pulse. We're going to look at that, of course, a little bit more deeply. So if we go and just look briefly at this section of the ABC, many times we look at the ABC as a linear process. You go from A to B to C, or you do one thing first. But the fact is that what do you do first in the primary assessment? Well, it's the one that's going to kill the patient first. That's why we take pathophysiology as part of an EMT class. You've got somebody that's got arterial bleeding from their radial artery or their femoral artery in their leg, right? They've only got a couple of minutes before they're going to bleed out. Now, if they're also in respiratory failure and have a big trauma and it's just you have to pick one. Well, what's going to kill them first? That bleeding is going to kill them first before hypoxia is going to get them. So we're going to fix the bleeding. So whether you have a patient that's got lots of junk in their airway and they've got gurgling sounds or snoring sounds that need the airway opened, respiratory failure or bleeding, you're going to find patients where there's a lot wrong and you just have to go and do what you have to do, but choose the most important one first. And what's the most important thing? Well, it's the one that's going to kill the patient first. Going back to the main primary assessment screen, remember the AHA says when a patient appears lifeless, use a CAB approach. Now that's important on the street. It's also important for the National Registry exam. The National Registry does pay attention to Heart Association guidelines, and you will get questions when they say you should next. You need to know that. So the lifeless patient, you walk up on a patient and you say to yourself, you get a feeling inside, uh-oh. And they're not moving, their color might be bad. Patients that are moving, that's a sign that they're alive. But the ones that aren't moving and just laying there, and as you walk up and start to kneel down, you'll look at their chest and you see their chest isn't moving, right? So we go to the CAB approach. We check the pulse first, and we can look at respirations at the same time. So that's really important. So transition. How do we get from the primary assessment into the secondary assessment, right? The old way, we looked at mechanism of injury. We looked at things that really don't have an awful lot of play in decision making. That's really not what it's about, right? We want to know how sick is your patient? What's their mental status? What have you had to do so far? They have, cool, moist skin. Are they sick or are they not, right? So in this visual we've given you, it's actually a continuum. Sometimes in the far red side, we got crashing, unstable people. People that just say, "Oh, I hope they don't code before they get in the ambulance," right? Then there are some when they may look stable, but they've got some time-sensitive issues, heart attacks and strokes. We have to move them promptly. So on the left side of this continuum, we have to load and go, or at least move them promptly, right? Now, we may want to give some aspirin for the MI patient and do some other things, but that's, prompt. But we also have patients that really aren't as time sensitive, and we're going to spend a little bit more time on scene. So as we transfer into that secondary assessment, what you figure out in your primary assessment isn't just fixing the ABCs, right? You may suction the airway, you may stop bleeding. We don't give oxygen as much as we used to, but our critical patients might get some oxygen, right? If their SATs are low or they look really bad. So you've done that stuff, and now you have to say, what next? The primary assessment should give you the information to get there and how sick your patient is. If you're coming out of the primary assessment and you don't know how sick your patient is, you haven't put it all together, right? Oh, they're talking to me. They got a great mental status. They may have broken their wrist. That's fine. It's not so bad. But the patient seems a little drowsy and they got cool, sweaty skin and they don't look good. The way we handle our secondary assessment with those patients makes a very big difference. So here's our secondary assessment, right? What do we describe this? What's our sentence to describe this? Perform a history, physical exam, and vital signs to determine what treatments, if any, are appropriate, right? So just a few things in general. There used to be an assessment of the medical patient, assessment of the trauma patient, and we still do things a little bit differently for those patients, but I'm not really sure it has to be broken out that much, right? The medical patient, generally we get more information from the history. That's a good place to start, unless they're unresponsive. And trauma, hands-on physical exam gives us the information. If we feel things that are broken, if we find bleeding, if we find bruising, we find a problem in their chest or their belly, the physical exam makes the difference. And of course, we've learned from the primary assessment that if the patient's serious, we're going to go fast and move the patient more quickly. And if they seem more stable, we might take a little bit more time. But here's the thing, assess body systems based on the chief complaint. Maybe it's chest discomfort or respiratory distress, abdominal pain. Maybe they fell and they hurt their hip. Whatever it happens to be, we assess body systems based on that complaint. Altered mental status, you may have to assess many body systems. There could be a lot of things doing this. Because here's the thing, as an EMT, you not only have things that you can do to treat conditions, sometimes you have multiple treatments that you can do with a patient complaint. If a patient has an altered mental status, we have naloxone for opioid overdose, we have glucose, and we can also identify stroke scales and cardiac, do the cardiac patients, we have to transport more quickly. So it is important for us to be able to figure out what's going on to do that. Some people say, oh, we don't diagnose. Well, you have to. If you don't come up with what you think it is, you won't know what protocol to apply. So the concept of differential diagnosis says we're going to come up with a list of possible causes and then rule each one in or out with your assessments or history. Think of all the things that can be wrong and you narrow it down. And how do you do that? You examine body systems, cardiovascular system, respiratory, neuro, musculoskeletal. That's kind of the trauma exam, right? Endocrine, the skin, the belly, and the reproductive, right? And these are sections that are on the National Registry exam. We add vital signs in there, and we come up with a conclusion. I think my chest pain patient has got potential for acute coronary syndrome, where my altered mental status patient has a diabetic history, and the blood glucose monitor says this, or their respirations are shallow to near zero, and I'm going to treat an opiate overdose. You've thought it out. This is not a rote process. This is one of the most important things you do. Most errors in EMS don't come from giving the wrong medication. They come from doing the wrong diagnosis, which leads us to the wrong medication. We don't reach into the drug box and pull out the wrong drug routinely. It can happen. We don't give too much or too little. More frequently, we don't give the right drug because we haven't come to the right diagnosis. And as EMS advances, as EMTs get more and more skills, this is so important. We add vital signs in there. That's important. There are times vital signs will be very significant. Things like increasing intracranial pressure. We'll see the pulse go down and the blood pressure go up. And narrowing pulse pressure, something else that we might find indicates shock. So then We match the suspected condition with the appropriate protocol to determine treatment. Right? It's funny, it's one sentence in there, but really it shows the value of the assessment. Once you get through the assessment, we have a protocol that's going to give us some guidance in what to do, and you can always call medical direction if necessary to help sort things out. Reassessment sometimes gets just only a little bit of play, but the fact is that there are times that patients become worse and we miss it, and we shouldn't. We have transport times, we have multiple things to do. Sometimes our patients don't seem to change much on the outside, but they're changing on the inside. We need to reassess the patient's complaint, see how we're doing with that. Any treatments that we've provided, make sure things are going well, and continually reassess the vital signs and mental status. The old curriculum said every 5 minutes for an unstable patient and 15 minutes for a stable patient, but the truth is that every 5 minutes is essentially continuously doing vital signs. Conversation with the patient, ask them how they're doing, how their mental status remains. Those things are all vitally important. So we took the sections of the patient assessment process from the scene size up to the primary assessment to the secondary assessment to reassessment, and tried to create a positive, intuitive, an easy way for you to think about the patient assessment process. You can download the PDF, click on your screen to be able to get that. Please feel free to share it with classes or colleagues or fellow students. And as always, you can contact us, support@limmereducation.com. Really what we do is we try and make EMS easy, understandable, and to help you pass the test. That's what we do here at Limmer Education. Thanks.
Okay, so can you guys hear me?
Yes.
Okay, so
Yeah.
in the process of downloading that form. That's not me, is it? That is me. Come on, Dan. I was like, what the hell is going on? Let me see where I'm going to put it. I guess I'll put it here. And so I'm logging in on my other computer to be able to put this document on there. So how is that explanation?
Okay.
Yeah.
Does that like it better than my lecture?
No.
Way to go, Rosie.
I don't like his teaching, the way you said it, that he uses CAB instead of ABC.
Uh-huh. Well, the CAB is started by the AHA because we need to be circulating that oxygen. But in a way, I'm old school, and I still don't buy worrying about circulation before you worry about airway, because there's only so much residual oxygen left in the body before you need to replace it. It's kind of like in some old cars, you had a second gas tank, and that's fine. You ran out in the first, then you switch to the second. But if you didn't refill the first and you're on the second, and all of a sudden you run out there, guess what? You got nothing else. And so that's the problem I have with that, is that it's only good for a period of time before you need to do something else about it. So again, that's just me being old school. Fire, we're very hard-headed when it comes to change. So I guess that's kind of where I'm coming from in a way. Okay, that was me. I just uploaded the that document that Dan was talking about. So now the other thing I'm going to do.
And you also put the chapter 12 or 13 PowerPoint, or the the PowerPoint.
I'll do that. Sounds like a beating drum. Okay, so here's another one. And this is what it kind of looks like based off of your form and the way that I taught it to you. Learning the format, learning the approach to it. So it's a little bit robotic, but it's also a little bit how it's done. But what Dan's trying to do is we're trying to show you a different way of doing it. And starting with the last class I did, I changed it up with them, so it wasn't as robotic as just talking with patients. But you could see the way that it goes. So let's see. Ow, gosh. I hate wires. I'm gonna go get some AirPods today, see if that works. So I don't have all these freaking wires to worry about. All right, so here's another one for you guys. And this is a lot shorter. It's about 7 minutes long, 7:43. Can you hear okay?
Yeah.
Okay.
Welcome to EMTprep.com. This is the Patient Assessment Management Medical Skill.
Welcome to the Medical Patient Assessment and Management Practical Assessment. Here we will evaluate your ability to assess a patient, interview them, and verbalize the treatment of all conditions you find. As you move through the skill evaluation, I want you to voice everything you are assessing. During the assessment, you will have 2 EMT partners to assist you. I may have to clarify treatments with you during the assessment as they arise. You have 15 minutes to complete this skill. You may take this time to review the equipment before you. You arrive on scene to a 24-year-old female who's complaining of difficulty breathing. Your scene is safe, and you may begin the assessment at the patient's side.
Okay. BSI, is my scene safe?
Your scene is safe.
All right. So based on my dispatch information, my patient's nature of illness is respiratory distress or difficulty breathing. Is this my only patient?
This is your only patient.
Okay. Right off the bat, I'm going to request an ALS ambulance.
ALS ambulance is en route.
All right. Based on the nature of illness and my patient's presentation, I don't think C-spine is something that I can consider. So general impression is I have a 24-year-old female seated in the tripod position, having difficulty breathing. As I walked in the door, she's alert and conscious, so I'm going to give her an A for level of consciousness. So, ma'am, my name's Dan. I'm with the ambulance. What seems to be the problem today?
My chest just feels really tight.
Okay, and it seems like you're having some difficulty breathing, is that right?
Yeah.
Okay, so her chief complaint is, again, difficulty breathing. So the first thing I'm going to do is move through my ABCs. A, airway. As I listen to her, can I hear air moving through just fine? Do I hear stridor or anything like that?
She is having difficulty breathing.
Okay.
But she is moving good air.
Okay, so she's moving air well enough. So breathing, I would assess a respiratory rate either with a stethoscope or by standing or watching and counting. What is her respiratory
She's
rate?
breathing at 24 times per minute.
Okay, so along with the breathing, I also want to listen to lung sounds. So can you take a couple of deep breaths for me? All right. Last deep breath. Okay, what are my lung sounds?
You have wheezes in all fields.
All right, based on that, I'm going to go ahead and put my patient on high flow oxygen right now. I'm going to use a non-rebreather and go at 15 liters per minute.
You can verbalize putting the oxygen on the patient.
Okay. So after breathing, we're going to move on to circulation. First, I'll check a pulse. What is my pulse rate?
Pulse is present, and it's at 96 beats per minute.
Okay. Do I note any major bleeding?
No major bleeding.
Okay. And then moving on to skin. Skin color looks pale. Do I note any cyanosis anywhere?
No cyanosis.
Okay. And as I feel it, does she feel warm? Does she feel cold?
Normal temperature.
Okay. And do I notice, is her skin wet? Is she sweating? Anything like that?
No. Normal.
Okay. So I'm going to go ahead and make this a priority patient. We'll try and transport her as quickly as possible. So next I'll move on to my my OPQRST. So ma'am, how long ago did this start?
About an hour ago.
Okay. And what were you doing when this started? What provoked this?
I was just watching TV.
Okay, just watching TV. And can you describe the feeling for me?
Yeah, it just feels really tight in my chest.
Okay. And on a scale of 1 to 10, 0 being not difficult to breathe, 10 being I can't breathe at all, where would you rate this?
Say about an 8.
About an 8. Okay. And again, how long has this been going on for?
For an hour.
Okay. So, and then after I've got my OPQRST done, I'll move on to my sample and try and get a little bit more information. So, do you have any allergies?
Yeah, I'm allergic to penicillin.
So you're allergic to penicillin. Are you on any medications currently?
Albuterol.
You take the albuterol, okay. And past medical history?
I have asthma.
Okay, so that's probably what the albuterol is for. What was the last thing that you took as far as food, last oral intake?
I had breakfast this morning.
Okay. All right, and events leading up to this, what were you doing again that caused this?
I was just watching TV.
Just sitting there watching TV. All right. So next I would move on to my secondary assessment. For this patient, I really want to listen to lung sounds again and reassess that. So I'll listen again. Have my lung sounds changed at all with the oxygen?
No, they're still wheezy.
Okay. Has my patient's ability to breathe, does she feel a little bit better with the oxygen?
She is breathing easier with the oxygen.
So after my secondary assessment, I would obtain a baseline set of vitals. So first I would acquire a pulse rate.
Her pulse is 90 beats per minute.
90 beats per minute. Okay, and what's her respiratory rate now?
The respiratory rate is 20 breaths per minute.
20 breaths per minute, okay. And lastly, I would get a blood pressure. All right, and what is her blood pressure?
Her blood pressure is 112/70.
Okay. All right, so now that I've got my baseline vitals, my field impression of the patient is that she's having an asthma attack. At this point, I would do interventions. If she had her albuterol inhaler with her, I could assist her with that. And then after that, I would continue to reassess her respiratory rate, her blood pressure, and her pulse as I waited for the ALS ambulance to arrive.
At this time, the ALS ambulance has arrived.
So I'll give a quick report to the ALS ambulance. So this is my patient. She's a 24-year-old female. Chief complaint was difficulty breathing. She has a past history of asthma. She has an albuterol inhaler for the asthma, or prescription for the asthma. Allergies are penicillin. Last oral intake was breakfast this morning, and she was just sitting on the couch watching TV when this attack happened.
Is there anything else you'd like to do for this patient?
Nope, that is it.
Okay, thank you.
Kind of robotic.
Yep.
Yeah.
Kind of. He has to use his imagination.
Yeah.
Yeah.
That's what makes it more difficult too. Is if you don't see it in front of you, it's harder to imagine what you have. It's better to see that patient that's cyanotic or sweaty. It's like she's having an allergic reaction. Okay, well, was she breathing hard? Was she pale, cool, and clammy? Did she have stridor? And then he kind of let him get off easy by the blood pressure, where he takes it, and then it's like, okay, you got this. No, let him work at it and give the blood pressure and say, no, your blood pressure is whatever he said. So we try to moulage the patients when we do scenarios. So you see the differences with patient assessment, and I don't want to confuse you guys, but what I'm trying to do is trying to get you guys to start developing how you're going to ask the questions, and then we need to put it together. Okay. What's the schedule like next week? Oh, you guys have a test on Monday, right?
Yeah.
Are you telling us or you're asking us?
Right now, I'm asking because I don't have the schedule in front of me, you smartass.
Making sure you're awake.
Oh, okay. Oh, okay. I'm going to can you guys make your groups smaller? About 4 or 5. Can you guys have your mask? Keep your mask on. Wash your hands, use your sanitizer, use your gloves, maintain as much as possible social distancing.
Yeah.
So I'm gonna try to work on, and I'd say maybe count on it.
Patient.
Yeah. Well, there's also med admin.
I could help out.
I'm gonna have to do the screening tool and get temperatures when you guys come in. Now, if we keep the group small, if you guys maintain all proper body substance isolation precautions, including myself, and if you feel comfortable, maybe going to the office to practice patient assessment and medication administration.
Yeah, that works.
Yeah, that works.
What day are you asking for though?
On Wednesday, because that's the next skills day. Although I'm debating doing Tuesday's lecture on Monday, and that way you guys go Tuesday and Wednesday.
Yeah. And then what are your hours or what you're looking at? They're going to take like 2 hours, right?
Yeah. And we really got to keep to the schedule because I don't want to have large groups there.
So there's 26 of us.
And actually, if we do, like I said, 4 or 5 groups, but 2 groups at a time. Again, half with Paul. I'll see if Paul's available. Half with Paul and half with me. So we can get about up to 10 done every 2 hours. But I really want to keep it small. I don't want large groups.
Then you want to start early.
Well, some of you guys are requesting it, so we could do the 7:30. That's fine.
Okay.
So 7:30 to 9.
7:30 to 9:30, and then
I
10
like
to
7:30.
12, and then 12:30 to 2:30. 12:30 to 2:30.
Yeah,
Because I want to have,
that works. It'd be broken up if they go both Tuesday and Wednesday. It can be broken up into 6 groups.
So everybody's gonna have to make sure they pick a time and date. So
Well,
things in and out.
I don't want to make it like either or. I want to make it both days
Oh, okay.
because you need that repetition.
That's
And
what I'm saying.
again, if you're doing an hour of pharmacology and an hour of patient assessment, yeah, pharmacology is easy. That's not going to be a problem to get done in an hour. It's just showing you how to administer the nebulizer, or how to set up the nebulizer, how to give the
Epidural.
meter dose inhaler, how to apply the EpiPen, how to assist a patient with nitro. So it's not too bad. So that's easy. Everybody can go through that. I mean, I have plenty of drugs that people can do stuff with. It's the patient assessment that's time consuming. So we can maybe get 2 or 3 max if we really bust our butt of scenarios. So really only one person, well, 2 people have a team, are doing a patient assessment at a time. So that's a lot more time consuming. So I'd rather get that repetition going. So I'd like for it to be 2 days.
Yeah, I mean, like if we do it, we break it down into 5.
Because again, I want to keep the group small and separate. And again, I'm still a little leery about it, but I'm going to leave it up to you guys. You know, I feel like if we take enough precautions, should be fine. But I'll still leave it up to you guys if you want to go or not. Okay. I think as long as we're making sure that people aren't sick when they go, making sure that proper precautions are taken the entire time, and that includes Paul and myself, and proper hand washing, everything, that we're gonna be good.
Good deal.
So I know I got we spoke the other day, Sequoia, or you sent me that message.
Yeah.
And I totally understand that, but I know you guys are getting antsy. I know that you guys are gonna be done in a little over 2 months. Today's the 14th, so in 2 months and a week. It seems kind of quick already because you just got started 5 weeks ago, but we're moving right along. So I want to make sure you guys get some hands on. I'm trying to figure out some other stuff to have you guys do at home, but yeah, you still need that hands on. But I'm not going to force it on anybody. I'm not saying listen to me, or I'm not saying listen to me and don't show up. I'm saying I'll let you make that decision. If you're sick, don't go. If you're not sick, cool.
What if you're a hangover?
Well, I'm hoping you're not driving with a hangover because that's still bad.
I'm joking.
Sure.
I'll pick you up, Rosie. Don't worry.
Oh yeah, that's what's up. I just have a banana bag ready for me, Lou.
I don't have banana bags. And
Got
all
it.
I have is expired fluids.
No, I'm good then.
I really don't drink, so when people talk about getting drunk or being hungover, it's like, how can you? And this is during the week. I can't fathom it.
Doesn't matter what day it is, dude. As long as it's a good time.
I have to be in the mood to drink. And what I kind of learned the last time I got drunk was don't get drunk around people because fucking cameras come out and then they try to burn you with it.
Man, hope I get money out of it.
No, I didn't get any money. I got some shit, but other people are like that was fucked up. Basically, somebody took a Snapchat video of me doing something, and they posted it. Well, somebody that worked for me was trying to get me fired, and so she screenshotted it and she was showing it around.
Haters, Lou. Haters, man.
Yeah.
Did you kick her in the kneecap?
No, because then I would have really gotten in trouble because she was the ex-lieutenant governor's cousin.
Oh, you're
What?
hanging around big time.
Huh?
You're big time then. You're hanging around big time then.
Who was it?
She's the cousin of the ex-lieutenant governor.
Even if you did say something, I'm pretty sure it would just be a slap on her little wrist and you go on without her day.
No, not when it comes to tribal government.
Tribal
I
concerts.
don't know.
You got to remember when you work for a tribal government, the normal rules don't apply.
Yeah.
They take the people before you.
Oh yeah.
Definitely.
It's like here's this individual that left her post during an event that they wanted a medical coverage for. A wrestler goes through the ropes, jumps through the ropes, lands on the outside. They didn't have any mats outside, just the concrete. He dislocated his shoulder. Well, they're looking for the medic. I was busy on a call. The other one was too. She wasn't working the event. And she left her post to go to the bathroom, didn't tell anybody to cover her. So then I'm hearing on the radio, we need a medic to the ring. And I thought it was kind of weird, but I show up and I figure out why. And then she's just standing there. And the dude's holding his wrist, holding his arm up because it's dislocated. She hasn't done anything yet. No ice pack, no triangular bandage, no sling. So I go in the bag, get an ice pack. I get the triangular bandage. I give it to her. She's just standing there holding it in front of her, like not knowing what to do. So a friend of mine ends up taking it out of her hands and starts to set it up. And the embarrassing thing was there was like 500 people around seeing her not know what the fuck she was doing. And they saw me come in and take charge.
Did she just have a baby?
Yes.
Oh, you're talking about my cousin.
Is she your cousin, really?
Yeah, she is, but I don't like her. It's okay.
Everybody's related to everybody there. Literally. Yeah, your cousin doesn't like me very much.
He doesn't like nobody.
And the talk is still that's not the boyfriend's baby.
I've heard.
Man, I got some real stuff going on, huh?
Oh yeah, that's a telenovela.
It's a drama on the res. Welcome to my world.
Yeah.
Apparently, I'm married and I have a boyfriend on the res.
Damn.
Good stuff. Sounds like work.
I don't even live on the res, and I'm already married and have a boyfriend. Where's he at? He could pay my fucking bills at least.
Yeah, it's a pretty interesting place. I do miss it, but it's difficult working for tribal government because you do have a lot of rules, and you're literally an at-will employee, and you can't sue them for wrongful termination. Now, other people can get fired like 10 times for different things, including drugs, and get a job back.
I've been fired 4 times since speaking wrong.
So you're back for your 5th?
Yeah,
Where'd you go? There you are.
right here.
I'm just waiting on Miss Sequoia to come back so I can talk to you guys about this. So you guys want to plan that for next week, Tuesday and Wednesday of next week?
Yeah, that sounds good.
Yeah.
Dealing with some cockroach infestment right now.
Oh.
As if you don't call 911 for a bug. I was showing Lou. We got a call yesterday for they called 911 to report there's a bug in their home.
The one thing I hate is cockroaches. Ugh, they freak me out.
Yeah.
Ugh, sorry.
That's right. So, one thing I wanted to talk to you guys about, we were telling you about Paul taking over as soon as we're back in the classroom. We don't know when that's going to happen. Now, a couple years ago, I was teaching a class, and I had to leave the class. My employer basically told me, oh, there was a lot of noise. My employer basically told me I had to quit ProAction. I didn't, but I had to drop the class. The class was very upset about it. It was hard on them. They thought it was something they did to me, which it wasn't. And so it screwed them up a little bit. And even at the end, they were still a little resentful that I left them halfway through, or not even halfway at the beginning. And so I'm kind of, I was thinking about that, and I was talking to Paul about it. And we kind of feel that the same thing would happen to you guys. You guys are getting used to me. This is already our 5th week together. To change even in a couple weeks again, we kind of got to wait till the middle of June, but that would only give you a month with him. And so I think it would be a little bit too much of a shock for you guys to switch instructors, really from this point on. So what we're going to do is I'm going to keep the class. Paul will still be around to help out, but I will keep the class. So I'll be your instructor throughout the whole thing. Paul's still available. He loves to teach. So that's what we're going to do. I hope you guys are okay with that. I hope you guys weren't like really excited about having Paul as your instructor. Maybe some of you were, but we just feel that it would be better on you. It would be less traumatic in a sense. Thoughts?
That'll work.
It sounded like
Yeah, you're good. Good.
Yeah, I think that's it.
Keep it as is.
Okay.
Yeah.
So now, mind you, he gives less quizzes than I do.
Oh, let's go ahead and switch.
Oh.
Hey, that's a joke. That's just a joke.
Oh. You just got kicked
That's
out
a
of
joke.
class.
Just laugh with that.
The only thing I shouldn't say I'm dreading, but the only thing like with my class right now is with my last EMT class that I did, 3 students have taken registry and all 3 have passed. So they were a good bunch.
Did Sareli take her test already?
No.
I know she's been studying really hard.
Hopefully she'll be ready. Yeah, she's pretty anxious. Yeah, so far 3 of them have done it and they've passed it. So, and that's because I test you guys a lot, the quizzes and then the long exam. So I want you guys to
Bad
be
idea
successful.
though.
What was that?
It's not a bad idea getting quizzes. I mean, you're testing us for our knowledge, what we're learning, so it helps.
So you getting us for the test, our national test too.
And Paul or Dan Limmer has a couple videos out too on dissecting questions, and you'll see it's the stuff that I tell you. That is why I'll be honest with you. I hate reviewing exams because they tend to be shouting matches. They tend to be, well, please give us credit for that one. No, it's not just, when I throw out a question, there's a reason why. And registry is not going to do that. The only reason I go over the exams is to start breaking down the questions so you could start getting yourself in the right frame of mind of how should this question be interpreted. And I think it was with you guys where that question on the PowerPoint, I got it wrong. And that's because I didn't read which is normal. I was thinking abnormal. And so that was a great example. It sucked. I embarrassed myself that way, but one, it shows I'm human, but two, it's like, this is what happens when you read the question. You don't want to rush through it too quickly and not understand what they're asking. And then kind of,
that was my mistake too.
What was that?
That was my mistake, reading through it fast or thinking outside the box.
Yeah, don't and Dan will tell you, don't put anything to a question that's not in there. Don't be, well, maybe it's this. I think it might be that because it doesn't say, but no. If it doesn't say, don't put it in there. They give you the information you need in order to answer the question correctly. So I will show you guys videos as we go along. So
go for national registry, would you say it's best to test like 2 weeks after we finish
not
class?
even 2 weeks. The best thing to do is to do excuse me, to do it as soon as you can. As soon as you get cleared, go in and schedule it as soon as you can. Don't put it off. They have found that the chance of passing decreases 10% every month that you don't take it.
That was my mistake. I waited a couple months.
Yeah. You gotta do it right away. A couple weeks? No, I wouldn't even wait a couple weeks. I would do it as soon as you can. The first available.
No, within the week.
Oh yeah, the best chance, yeah.
Because I'd be able to test like within the week if they have openings.
Yes. Once you're done for Robin, this is Robin?
Yes.
Yeah. Yeah, yeah, you're still cleared. You have 2 years. Has it been 2 years yet?
The 2 years are up in September.
Okay, so you wouldn't have to wait for me to clear you because you've already been cleared. So yeah, you could even schedule it before we get done so you're ready to go, and it kind of guarantees that you'll have an early enough test.
Okay.
And I've had students tell me that National Registry was easier than my tests.
I know one of the questions you had.
Uh-huh.
I know one of the questions you had yesterday, I think, or were on the registry. I recall one of the questions.
Mm-hmm. So you know the method to my madness. I'm trying to get you ready. Repetition, taking tests, taking quizzes, getting used to it. As we go further along on EMS testing, they have an adaptive test component that you can go in there and take tests, and you can concentrate on certain areas, or you could do like a whole national registry thing to get used to the tests. It's a limited test bank, but when you run it through a couple times, it's good. And then you can get outside programs. Dan has EMT Prep or EMT Ready. They have apps for questions.
That one happened.
Yeah, actually, let me do that. I think I'm still logged in over here.
How many questions are going to be on the National Registry?
Up to 120.
There's a.
I know it kicks you out if you're doing really bad.
Well, yeah, it all depends. The one thing about registry is you can't be too confident, because if you come out of that test, you're like, I aced that thing. Guess what? You probably failed it. If you come out of it like, what the hell was that? If you feel like that's the worst experience ever, you probably passed it. If it stops you somewhere along the way.
Isn't it a 60 or 70? It stops you at 60 or 70. You failed it.
No, the earliest I could stop you at is 70. But no, it doesn't mean anything. It could mean that you passed, or it means that you failed. You just don't know. Now, there's apps, EMT Review Plus. I could when I contact them and get a class set up, they usually offer a discount on the app. I think normally it's like 11 something, but it has different things. Let me share this with you guys. So I'm going to shut this thing off for a bit.
You guys hear me?
Yeah.
Can I hear you?
Yes.
Yeah.
Yes.
Oh, now I can hear you guys. I don't know why that was. Okay. So you guys can see my screen?
Yeah.
Okay, so this is EMT Review Plus study menu. So prep. Because we've already done prep, right? Actually,
Yeah.
let's do assessment since we just did assessment. Okay. So card one. Actually, no. No, I didn't like that. Okay. So question one, what portion of the blood pressure cuff should be over the brachial artery? Is it the portion opposite the Velcro? Is it the center of the cuff? Is it the tubing or the center of the bladder?
The tubing.
Think it's the tubing? What do you think, guys?
Yeah. I don't remember.
Nope, the center of the bladder. And what I've done before in classes is there's a competition between groups. I've been known to give money away. One time got $20, not each for the group, and the losing group got $10. It's a pride thing. One half of the room against the other.
It's on.
So we can still do it here.
Just kidding.
All right, question two. Pleuritic chest pain refers to pain where? Which is in the throat, which radiates to the other shoulder, which can't be differentiated between chest and abdominal origination, or which changes with breathing?
The third one.
Au contraire, mon frère. What's pleuritic?
A sudden, intense, sharp, stabbing, burning pain in the chest from inhaling and exhaling.
Okay. Now use your own words.
Oh, the last one. Exhaling and
When you have like a,
Sharp pain.
yeah, like a,
an acute.
Okay, you remember the pleura?
The lining
The lining where?
of the lungs.
In the lung.
Okay, you have lining covering the lungs. Which pleura is that? Visceral or parietal? Or parietal?
Visceral.
Visceral. And which one's the parietal pleura?
The inside lining.
See outer.
Yeah, it encapsulates the chest cavity, right?
Yeah.
Now let's go back to the visceral pleura, the one that covers the lung. What is the purpose of that pleura?
To lubricate.
Okay, so there's fluid within the pleura, right? Between the pleura, the pleural sac, and the lung. Okay, so that pleura moves along with the lung. The lung's expanding there, and there it goes. It helps lubricate as it expands and collapses. All right. So what happens was when there's an infection within the sac, within the fluid?
the inflammation.
Does what?
Goes to the bronchioles.
Nope. It's
Yeah.
enclosed within the lung or within the pleural sac. It's not inside the lungs, on the outside of the lung. Have you ever maybe wore pants a little bit too tight and then you chafed?
Yeah.
And it was usually like in a certain area where you chafed? I got like 25 people in the room and not a single person speaking.
I said yes.
I know, but then I asked another question.
You said shaving what?
Chafing.
Oh, chafing.
Yeah, chafing, like rubbing you raw, like in between the legs.
Yeah.
Yeah.
Your thighs.
Yeah, your thighs. Thank you.
Definitely.
I'm already starting to think about my mojitos. Hint, Miss Rosie.
I know. Better start. I want potatoes and bacon.
Hey, I'm hungry now.
Well, yeah, we talked about Thursday brunch.
You're cooking.
Yeah.
You're hungry.
I'll stop at the Food King by your house.
Someone has to help me cook.
Was it?
Someone has to help me cook.
I'll help you cook.
I will too. I can make you guys some fresh tortillas.
Oh.
What?
Now we're going Mexican style now. I want some huevos rancheros.
I was just thinking about some French toast, bacon, coffee, and a mojito.
I'm just sitting watching TV.
Way too fast.
And a cigar afterwards.
What kind of cigar though?
What kind of what?
What kind of cigar?
Well, you know what? I'm kind of weird. I like the Blackwoods. They're not like the Swisher Sweets. They're not the bigger cigars. They're kind of like the old time Western cigars.
It sounds nasty.
Yeah, I mean, if you get the flavor, it's something relaxing.
When you come home penetrated with cigar. Ugh.
Well, that's you though. Well, they're not smoking in there anymore.
No, but before that,
You don't have to remind me. Remember, I don't know if you ever saw my office, but I'm in, like I told you, that office that's in the back corner of the CB room.
which is a storage room now.
Yeah, which was before. And then Carl had them empty it out so I could have my office. But yeah, it reeked of cigar or cigarettes. I leave jackets there and I'd get back and it's like I put them on. It's like, oh man, they reek of cigarette. Granted, I
Right.
smoked too, but it was worse.
I will come home smelling like an ashtray.
But yeah, I like the Blackwoods. They're pretty good. But anyway, so speaking of the chafing, let's forget about lunch for a while. Speaking of the chafing, the rubbing. So that's what's happening with the pleural sac. That's what pleuritic chest pain is when you have an infection, as you breathe, your chest starts to hurt because of the rubbing or rubbing the lung raw. So what does the throat have to do with the chest? In this case, nothing. Radiate to either shoulder, no, you're probably talking about the pancreas or the gallbladder. Can't be differentiated between chest and abdominal origination, or you're talking about referred pain, but
That's more about abdominal though.
yeah. I mean, I could stick with C here if you want to go with D. Again, I could be wrong.
I think D.
Yeah, I think D,
D.
too.
Phew.
Ah.
Pleuritic chest pain is that which worsens with breathing or coughing. It is often seen when there is irritation of the pleural linings of the lung, although this is only one potential cause. Which of the following describes a patient who is verbal on the AVP scale? Patient moans when pinched. An oriented patient who speaks easily.
The third one.
There was a lot of noise, so I was going to mute them, but
Turns the face.
Turn to face EMT.
turns to face EMT when asked a question.
Yeah.
Yes.
Or a patient who is screaming in pain.
Yeah.
Yep. Next, which of the following is not checked during assessment or reassessment? Interventions, blood pressure, past medical history, or patient complaint?
Medical history.
Patient
Medical
complaint.
history.
Complaint.
Complaint.
No, because that's the chief complaint, right?
Yeah, we want to see how it's better.
Past medical history.
Yeah. It would be the medical history.
Because complaint, we want to see how their complaint is.
Yeah, that's the
Better
first
what
thing.
Oh, then that goes to the assessment. Gotcha.
Yeah, there's no need. You already got a past medical history. How did it change in the last 10 minutes
Right.
or 15 minutes? It didn't. So it's past medical history. If a patient has orthostatic hypotension, the pulse will do what when the patient does what?
Can you zoom in a little bit, please, if possible?
Everything's possible. Better?
Yeah.
Is it going to be decreases? You stand up?
Doesn't it increase when he
It's an
stands?
increase.
Yeah.
I would say increase.
It's
First one.
So which one are you guys say? A or B?
A.
C or D?
A.
No, I think it's decreased when standing up.
Because they it's already increased, isn't it, when they're sitting, when they're supine?
Because
So then
isn't it orthocystic hypotension? Hypo is low and hyper is high.
Right.
So it's going to decrease when standing up.
because that's when you wait.
The blood pressure changes
I
when
think
you
it's gonna
stand up,
increase.
though.
It's gonna increase. It's gonna increase because when you stand up, like sometimes if you stand up too fast, you feel lightheaded. So I think it might
The
increase.
first one.
Yeah, it's the first one.
Man, you guys are not respecting your president.
Oh
Yep.
man, come
Told
on,
you.
President.
Wow.
Orthostatic hypotension is observed when the pulse increases, usually about 20 a minute, after the patient stands or sits up. Patient may also become dizzy or weak. Usually indicates hypovolemia.
That's why you check their blood pressure in two forms: sitting up or standing up.
And what's the blood pressure going to do?
Decrease.
Decrease.
The blood pressure cuff should cover what portion of the upper arm? Three-quarters, 1/3, 1/2, or 2/3?
1/2. I don't know. It depends on the person's body.
2/3? No.
The upper third? Way up here?
I guess it just depends.
On the person's arm, or do they have a large arm?
Or a tiny.
So what is it, Lou?
I don't know. Tell me.
Two-thirds.
2/3. I think 2/3.
Yeah, remember, proximal, medial, distal. So those are thirds.
Yeah.
And you want to be away from the crease of the elbow. So if you look at it, it's covering up about at least 2/3 of the upper arm. Because sometimes that cuff goes like right underneath the armpit.
Mm-hmm.
Normally body temperature is what in Celsius?
97 or 37 degrees.
Nobody's answering because they don't know. But yeah. Last one. The medical radio report provided to the hospital when transporting a patient includes which of the following? Patient's race, detailed patient medical history, all sets of vitals taken, or chief complaint?
Radio.
What?
The vital signs.
Chief complaint.
Chief complaint.
When transporting a patient includes which of the following? Okay, so medical radio report. So I think
it's
gonna be.
I mean,
Chief
it could
complaint.
be both chief complaint and vital signs where they could know how stable the patient is.
Yeah, but you're right. You want to give them a set of vitals, but you usually give them the last set of vitals.
Yeah.
It should be
But
what
where
the
this is wrong, it's all sets of vitals. No, you could give that to them at the hospital. Radio report, you want to make it quick, easy, done and dirty.
Yeah, because they don't get chief complaint.
What about like detailed patient medical history?
No, because that's detailed. Who cares that they have?
Oh right. Oh yeah.
You know that they've had scabies, that they've had psoriasis, that they have they had a TIA 30 years ago, that they have glaucoma. If it doesn't pertain to if it doesn't pertain to the chief complaint, then that could wait. Like I said, it's down and dirty real quick.
So are you gonna contact this place, or are we allowed to use this?
Yeah, you can call the hospital. Yep. Which is nowadays I don't say it's weird. It was for me initially, but when I worked in when I first started as a paramedic, even when I first started as an EMT, only paramedics could call the base hospital and give a radio report.
No, I mean like the overall website of this, the LC.
Oh, yeah, it's LC Ready. And let me. See, these are classes that I've set up with them.
Oh.
My apps. So as an instructor, they asked me, what classes do you teach? And I told them. And so they gave me free access to these 3 classes. I'm going to see about getting more from other classes, but EMT Review Plus.
You create a study group.
Yeah. Now you guys have to pay for the app, but I could, when I tell them, they usually send me a coupon code. That's like 25% off.
That'll be nice.
So what I could do is, see, I had one guy go on there, and I could see how you guys are doing, and I could maybe adjust lectures or something based on how you guys are doing. So, and she actually emailed me last week, so I got to respond to her. But
So can you set this up for us so that way we can like kind of look over it or like start doing some of the reviews?
yeah. And this is what I was telling you during orientation when I talked to you, each of you individually. We're going to do what we can to help you achieve your goal of becoming an EMT. So there's things like this. Not everything is free, unfortunately, but it's something. You know, you're seeing more questions, and like I was telling you, the more questions you see, the better you are at recognizing what they're asking. And so when you're taking registry, you're more prepared. And as a couple people that have taken registry in here have mentioned, yeah, my tests are harder than National Registry, but they've passed. Like the kid right here, I call him a kid. He's in his like mid to late 40s or 30s, so he's still a kid to me. He passed registry. I was surprised, but he made an effort. I mean, he didn't do so well, but he made the effort. So we try to do what we can to help you guys be successful. So yeah, I will reach out to her, tell her I need another code, and I will get you guys that info so you guys can log in there and create an account by the app, and do that.
That's fine.
Awesome.
All right. Not that I want to get rid of you guys early, which I really don't, but
Brunch at Rosie's, remember?
yeah, she has to text us her address. I'm just gonna get ready and start heading out.
I'm losing signal. I can't hear you.
Uh-huh.
Oh, all of a sudden.
In other words, we're not invited.
That's what it sounds like.
Hey.
Having second thoughts, cold feet.
Hey, no, Sequoia makes those tortillas she was talking about.
Right.
You're invited all day, all week.
I'll make some chilaquiles. My style chilaquiles.
That sounds good.
I don't make them with egg, and I don't like them red. I don't like them spicy. So, but anyway, no, I think we've covered a lot. I think I put more information to your head today, something to think about. I want you guys time to have time to process it, and also extra time to start studying for the exam on Monday. So what we'll do is take the exam. I'll send you guys a message or probably an email, one of the two, to let you know how many questions the exam is, and then kind of give you an idea. But I figure,
What is it going to cover mostly? Like, I know chapter 13. Are you going to go put some more chapter in there?
Let me do this. It's part 5 and 6 exam, right?
Yeah.
Yeah, 5 and 6.
I don't know if it's 50 or 82. I have 2 tests. I'll be nice. I'll give you guys the 50.
And it's on.
82 gives us a higher chance of passing.
Yeah, I can give you the 82.
No, thank you.
So here's an airway question. What maneuver do you use?
But it's over chapter 12 and 13, right?
Yeah. That's why I combined the two, because part 5 is just airway management.
Okay.
And then part 6 is just patient assessment. So instead of having 2 separate tests, you have 1 test.
Does anybody want to do a study group for these chapters?
Yeah, that's what we're doing with brunch.
Oh.
Remember, it's a study session.
Yeah, but for the test for Monday.
Yeah, we're studying at your house. After we get a few mimosas in us, then we'll be good.
Yeah. See, if you get the teacher drunk, then loose lips will give answers.
There you go.
Just kidding, guys. I'm not like that.
I'll go to Western Beverage right now.
I'll meet you there.
Or Specs is open too.
All right. Any other question, guys, that I could answer for you?
Nope.
Nada?
Nope.
So it's just over chapter 13, 50 questions.
12 and 13, 50 questions.
Okay.
And then I'll be working on grades. I'm trying to catch up. So if it takes me a while to get everything ready. You got to remember that I'm managing 3 classes, or I'm teaching 3 classes. So there's a lot of paperwork I have to do, a lot of grading, a lot of stuff. And in addition to that, I'm coordinating 2 other courses that I got to stay on top of. And then in spite of all that, I still have other admin stuff to do that I need to do for the school itself, because I do run the school. So there's stuff I have to do at that in that respect. So if I don't get your grades done pretty quickly, just please be patient with me. Understand that it's not that I'm laying in bed and just being lazy all day. It's because I have other stuff to do, and I do get hungry. I like to eat. I like to take a shower every once in a while, you know, once a week. So it's already that time of the week for me to take a shower, unfortunately.
Oh.
It's like TMI. I'm just kidding.
Uh-huh.
Well, you better shower if you're going to go to Rosie's house.
Yeah.
Oh, I will.
Or we're
My
going to
dog will smell you.
Or you won't let me in.
My dogs will smell you.
No, we'll just get a water hose and dump some water and put some soap in there maybe.
Oh, you never tell a fireman that you're going to hose them down, because no, it's never a pleasant experience. Because they tend to get carried away and aim the stream right at the gonads.
No, it just reminds me of Super Trooper.
Have you seen their new show? What is it called?
Isn't it? They're firefighters, right?
Uh-huh.
Yeah.
Oh, it's hilarious.
Oh yeah, where is it at? I remember seeing that it was they were shooting it, but I've never seen an episode of it.
Hulu.
Yeah.
I don't have Hulu. I don't like
Well,
commercials.
it doesn't have commercials. You could pay for it, won't have commercials. It's like $14 a month.
Exactly. I mean, there's shows on Hulu that I want to watch, but I don't want to pay that much.
Well, keep watching commercials then.
Although I'm not. No, I have Netflix. I have Amazon Prime.
It's called Tacoma Fire Department.
Okay. Well, I'm gonna cancel my CBS All Access subscription anyway, so that'll free up some money. And then Netflix, I don't pay for it because I'm a T-Mobile customer, so I get Netflix for free. Yeah, maybe I'll do that. Maybe. All right, guys. Anybody else have anything?
No, just I'd say make sure everybody does their pre-tests and homework before Monday.
Yes. Get your homework stuff done. Get your homework stuff done.
Other than
I
that,
did the pharmacology one. It was pretty easy.
Yeah, at the EMT level, it's not too bad.
it was only like what 16 questions, right?
Mm-hmm.
Yeah.
Hey.
My dog is such a lazy little girl.
Mine keeps wanting to bark right below me.
Mine? Have you heard mine bark?
You want to see you?
She's sleeping. She's right behind me.
Mine barks for everything.
See, there's mine back there, that white ball.
It's like one of those sheepskin blankets.
It's not, but it's a very warm blanket, and she loves being on the bed with me. Oh, damn, that's a big baby. It's about as big as you.
It is.
I love English Bulldog.
Is he
I
a
do
boy or a
too.
girl?
He's a boy.
He's a boy?
Yeah.
You don't have a girlfriend?
No, I want to get a girl, but there's so much.
I'm about to breed mine. I'll show him to you later.
All right.
He's an English Bulldog.
Mine had puppies yesterday while we were having class.
Oh, how
Oh,
cute.
dang.
Shih Tzus.
It's so cute.
I'm gonna get another dog, but this one would probably not take it very well.
How much are you selling yours for, Rosie?
The last litter I sold them for 400.
My brother wants a girl or like a partner for his.
I didn't even know she was having her puppies.
Yeah, I want to get an English Bulldog, but I don't like really big dogs. I mean, I like the breed, but I just don't like big
It's
dogs.
a miniature English bulldog.
Yeah, but I don't want to pay $800 to $1,000 for a puppy.
I like how he's sitting there so calm.
He's learning. See, that's a good student right there. Except he's not taking notes.
Take notes.
Is that the mama?
No, this is the other litter. They're like 4 months. The mama's right here.
Cute.
Yeah, I like small dogs like that. That's the dad?
Yeah.
Where are the cigars at, Dad?
He's a little hoe.
He's a little hoe?
He already got my 2 females pregnant.
Jeez. Man whore.
Mm-hmm. I like how he's just sitting there, Sequoia, like, what's up?
He hears all the dogs, that's why.
Oh.
Hi, Juan. Nice to see you.
Hey,
You do exist.
I do. And I'm
I
here
only
with
see one
my
Sequoia.
doggy.
What kind is it?
Labrador.
Ah, those are good dogs. I used to have cats, but they scratch too much.
I'm not a cat person.
I'm allergic to him.
I used to be, but they ruined a lot of my stuff, and I got nasty scratches from them. I'm like, fuck that. And they're way too temperamental. Way too temperamental.
The only time that we had a cat was when I was growing up. I was about 5, and we grew up with it. It was a Siamese